All right, good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19, infection control, and other nursing home related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today's webinar is Multidrug-Resistant Organisms, an overview. Everyone has entered the meeting on mute, but we will have a Q&A following the presentation. If you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. We invite you to join us every Wednesday for more of our weekly webinars. Next week's topic will be a follow-up on enhanced barrier precautions. If you're interested in joining, that will be the same time and place next Wednesday at 2 p.m. And now, excuse me, and now I'd like to introduce our guest today, Valerie Jividen. Valerie is an epidemiologist with the Lab Epi Liaison for the West Virginia Department of Health, Bureau for Public Health, and the Office of Epidemiology and Prevention Services. Her passion for infection prevention began 30 years ago when she earned her ADN from the University of Charleston. Being a lifelong learner, she later earned her BSN, followed by an MSN and a Master of Science in Healthcare Administration. She leads West Virginia's MDRO program as part of the HAI-AR team. And when not at work, she enjoys spending time with her family and miniature dachshunds, Helga and Ava. Valerie, thank you for joining us today.
Thank you for having me. I am glad to be able to take some time to talk with everyone today. And the first thing that I want to go over is our MDRO toolkit that you should have received in an email. So bear with me. Can you see the screen there?
Yes, and I just put the link to that toolkit in the chat.
Okay, thank you. So, this is pretty self-explanatory. We wanted to make it easy for people to understand what is a multi-drug-resistant organism, what do I need to do about it, and it's just a concise record that that you can refer to and be able to find your information quickly. So, at the top of the screen, you see that we've put some definitions there. One is multi-drug resistant organisms, and this is something that not everybody understands. You would be surprised at some presentations I've done before, and even healthcare professionals, some don't even understand what MDROs are. But it just means that it's bacteria that is resistant or non-susceptible to one or more classes of antimicrobial agents. I'm sure you are all familiar with MRSA. You may have heard of VRE. The one that we focus on here in West Virginia, and it's not a single organism, but we track carbapenem-resistant organisms, and that includes the entire family of Enterobacterales, but it also applies to Acinetobacter and Pseudomonas. Just last year, the two additional types of organisms were added to what we track, and that actually was a national event because crab in particular, or carbapenem-resistant Acinetobacter baumannii, and the carbapenem-resistant Pseudomonas aeruginosa are two organisms or infections that are increasing greatly in numbers across the country. And so we overall are working to reduce the number of those types of infections. Also important to know when you're talking about MDROs is the difference between a patient or resident being colonized versus a true infection, an active infection going on in the body. Colonized means that the organism is present. It could be a novel or targeted MDRO, and it can be on an individual's body without causing any kind of signs of infection. So you don't know it unless you've been tested to see if you are colonized, but many people don't even know it and are unknowingly spreading those germs. Now, active infection of an MDRO, you'll have signs of infection, fever, lesions, wound drainage, any of the typical types of symptoms that you see when you have an infection. Case definition would be a resident who is newly identified as infected or colonized with an MDRO. And many facilities, nursing homes, acute care, different levels of healthcare facilities will sometimes do colonization screening. And I'll talk about that more in just a few minutes. Another question that we get often is outbreak. What do you consider an outbreak? So the general rule is if you have an increase in the number of MDRO cases above what you expect or whatever your endemic level or baseline level is. So, for instance, Candida auris is something that is at the top of our priority list now. And so you wouldn't expect to have anyone in your facility to show up as infected or to have an active CRS infection happening. So it would only be one person that it would take to be considered an outbreak. A note here that's important, and I don't know, it's not so much of an issue now, but during COVID, I'm sure many of you are familiar with people were nervous about transferring from acute care into long term care. And so we did add the fact that it is not valid grounds for denial of admission. So we were having some acute care hospitals that were having trouble placing residents into long-term care. But thankfully, COVID is mostly behind us now, and this isn't such an issue at the moment. Any questions about any of that before I go on? Okay, please just feel free. We have a small group here, and I want you to feel comfortable asking questions or making points. You can maybe add some insight that the rest of us could use too. So, before you have an outbreak, we have outlined some actions that you can take in order to take better control of your outbreak. There are administrative measures. We would expect leadership in facilities to make MDRO prevention a priority and implement some sort of system to communicate MDRO status. That is the whole communication piece of MDRO status is so extremely important. Not only do we need to make sure that healthcare providers understand what an MDRO is and how to treat a patient that is colonized or actively infected with the MDRO. And we further need to empower patients and their families with the same information regarding MDRO status. That person that is colonized, for example, would need to be taught and plan to let any other healthcare providers in the future know that, hey, I've been colonized with this multi-drug-resistant organism, and I understand that this is something that I will need to be aware of indefinitely. So that piece to patients and families is something we need to work on. But also administrative leadership, they need to make sure supplies are readily available. Basic hand hygiene needs to be available, accessible, and conveniently located. The hand rub, the alcohol-based hand sanitizer, staffing levels need to be such that infection prevention is not on a lower level of priority. It needs to be at the top. And then, as was mentioned, the enhanced barrier precautions should always be considered. And that I wouldn't be able to tell you a lot about today. But if you have questions, you can always send those to me and I can get more information back to you. The education to staff should be conducted upon hire and then annually if needed. And then residents and visitors also need to have education on the importance of hand hygiene and infection prevention practices. And then ongoing surveillance. It's important that leadership conducts audits for those basics in infection prevention, hand hygiene, PPE, appropriateness, and use, and also the cleaning and disinfecting. Um, so many people don't understand there's a difference between the two, and cleaning is basically getting rid of any visible soil or any kind of equipment that may have visible um, whatever on it. But disinfecting, that's when you take your disinfectant and the wait time and get rid of bacteria that way. Um, Leadership should be reviewing their compliance data, addressing any gaps, and providing education when those gaps are identified. And then it's important to track the MDRO status of residents. I know most of you probably could readily tell me now how many people you have in your facility with an MDRO, and that's just important information to track. On page 2, top of the page, it says colonization screening upon admission. That is one of our top goals as a program, to work with facilities, nursing homes, and long-term acute care facilities to try and provide colonization screening. And simply because if you catch that person as they are coming into your facility, you're able to identify if they need to be in contact precautions, and you can keep the rest of your residents safe by knowing ahead of time if the person coming in does need to be in a private room and so on. Antibiotic use and antibiotic stewardship. Hopefully, many of you are interested in joining our medals program, and a big part of that is that you have antibiotic use and antibiotic stewardship in place at your facility. But we want to recognize groups of people that do consider this antibiotic stewardship a part of their day-to-day practice. Excuse me. When you have an outbreak, this was all to prevent, but when you do have an outbreak, it should be reported immediately to your local health department. Your infection preventionist at your facility needs to be notified. And then bullet 3 there, consider obtaining infectious disease consultation. If you're able to have, or if you do have an infection disease specialist on staff or available, that's awesome. But you can also notify us here at the HAIAR program, and our nurses would be happy to come out and work with you to identify gaps that may be present. You need to have appropriate signage so that people understand and know what they need to do to take care of themselves. And then if you have an extensive outbreak and an MDRO is involved, then that's when you may consider restricting admissions, but that would have to be a fairly significant outbreak before that could happen. And then education, always important. Surveillance. One of the bullet points here is to start a line listing of all known infected and colonized. And if you are unfamiliar with a line list, again, you can notify us. We'd be happy to work with you and go over how you need to do that. If you do have an outbreak, then you would also want to review 3 months back before you identified that colonization or infection. And then you would want to prospectively work with the lab that is doing your testing to identify any unrecognized cases of MDRO. Surveillance would need to also be those or hand hygiene, PPE, and EVS audits. And when you do have an outbreak going on, we recommend, and this is not set in stone, but this is a best practice, to conduct 10 audits per shift during an outbreak. You can do more, you can do less. That would be up to you, your facility policy, but that's the recommendation. And that does include evening, night shift, and weekends. And the last page of the toolkit goes over testing when you have an outbreak. And we're able to, any isolates that we get, that we identify, we're able to work with our national lab in our Mid-Atlantic regional lab, I'm sorry, excuse me, to conduct molecular typing. So that means that CRS, for instance, if we have a person who has a CRS infection, we can send that isolate off to our regional lab in Baltimore, and they can do whole genome sequencing. So they're able to, and this takes many months. The technology is getting there, but it's still fairly new. But we're able to do DNA testing to see if one Candida auris is in the same clade or has matching DNA as another patient's Candida auris. So that will help us to be able to track better. And it's an exciting new field frontier for healthcare, but more to come on that. Room placement. If you have someone who has an MDRO, of course, they should be in contact precautions, preferably in a single patient room. If they can't be in a single room, then there are steps you can take, such as pulling the curtain between two beds and so on, that you can do to minimize the risk. Increased cleaning and disinfecting needs to happen whenever you have an outbreak happening. And if you aren't sure if your disinfecting agents are appropriate for whatever your MDRO is, for example, Candida auris, you should look at List P on the EPA's website, and it can tell you exactly if whether or not your particular disinfectant is effective against that particular organism. So, a final point here, consider assigning dedicated staff to target areas. Very difficult to do, I understand, but as much as possible, that is the best practice. These guidelines are not a substitute for a literature review. And although we are always making sure our resources and tools such as this is up to date, it does change. So we will pass on more information as it comes. Are there any questions about any of that? All right. So I do have my Candida auris presentation that some of you, we were just talking about it, but some of you may have already seen this. If you have, forgive me. I'm going to quickly go over it, and we can't do the whole thing, but as much as possible. Candida auris, calm, not chaos. And we named it that because when we got our first Candida auris case early last year, there was a lot of stress and a lot of anxiety around this. Some of the things we heard people say was, oh my goodness, this is going to be another COVID. No, it isn't another COVID, thankfully. And we've learned a lot through that pandemic experience. But the message here is to stay calm and avoid the chaos that Candida auris can cause. The objectives for this presentation are to review the definition and background. We'll talk a little bit about prevention and control guidance, the screening process, roles and responsibilities of everyone involved in an outbreak or identification of a positive lab report, then go over some frequently asked questions. And I'm not sure if we'll get to do the studies or not, but we'll see. So, cloudy with a chance of multi-drug resistant organisms. That's the umbrella term for all of these bugs you see here with the red pow bang kind of pictures. But you have CRE, crab that I mentioned, CRPA, everybody's heard of MRSA and so on, C. diff. All of these fall under that multi-drug resistant organism umbrella. So all of that alphabet soup is all talking about the same thing. Next slide. CRS is an emerging multi-drug resistant yeast or fungal infection. It can colonize the skin and cause very invasive infections. It spreads readily in healthcare facilities and is responsible for causing many outbreaks. Containment is very, very important, and quick detection and implementation of the appropriate prevention and control methods are vital. Um, this bug is sort of like C. diff in how it needs to be cleaned. It has a tough outer surface that makes disinfectants, makes it harder for them to do their job. So it does take extra effort. Next slide. Why is this a problem? It causes some very serious infections. It can be bloodstream. You can have it in urine, sputum, any body substance or skin. You can have this infection anywhere. And it's particularly important in nursing homes and in long-term care facilities because that population is very vulnerable, morbidities, and it's hard to get under control. More than 1 in 3 patients die within a month after they've been diagnosed with an active invasive Candida auris infection. Keep in mind, this is active infection, not colonization. And we are seeing out of all of our CRS infections that we've had so far in our state, there's been about 11 or 12 active infections. Um, just anecdotally, probably a fourth to a half of those patients have passed away within the month. That really solidifies that fact that it's highly it the mortality rate is very high. And CRS is commonly not going to react to or be um, controlled with the infection or antifungals that are out there. Those big gun classes, the diflucan, amphotericin B, and micafungin or micamine, they are not do not work against CRS. So that's why it's so difficult. There isn't really a whole lot you can do to treat it. It is becoming more common. It was just discovered in 2009. That was the first case, actually, was a woman in China who went to the doctor, was having an ear infection, and they discovered it then. That's how the name auris came to be. That's Latin for ear. So that first female in China had it, and now it has spread around the globe. There are 5 or 6 different families or clades of Candida auris in different parts of the country. There's one that is named the South American clade, um, the Iraqi or Iran clade of Candida auris, but that's a whole other subject. I won't take time to go over that. Next slide, please. Difficult to identify. Often a lab will identify Candida auris mistakenly as another type of Candida infection. So we always need to make sure the lab is using the appropriate method for testing, and that they can confirm those results. And we encourage labs and facilities, if you aren't sure, then you can always submit it to us and we can look at it and decide if it is truly a Candida auris infection. The Centers of Disease Control added this to the 2019 urgent threats list. And you can see their 318% increase in cases were reported in 2018. The CDC now, this month actually, is updating their interactive map that shows how many Candida auris cases were reported in every state. Well, next slide, and I'll show you that. There we go. You can see this is from 2022. We are colored gray along with South Carolina, North Carolina, and a lot of these Midwest and Pacific Northwest states. Unfortunately, and that gray means there were no cases in 2022 in those areas. The red color is the highest number of cases. Next slide. In 2023, actually, February 23rd is when we did have our first case reported, and it was in our northeastern surveillance region. That would be the eastern panhandle. But there were no colonized patients identified during the screening process, which was wonderful. Then we had 2 additional cases that were identified in March of last year. One was in the western region, and then December 6th, we had another northeastern region later in that same year. Actually, I need to actually update this slide, but we have now had 11 or 12 index patients so far as of today. Index patients means that was the first person to be identified and not connected to anyone else. So we are heading in the direction of having more and more cases. Next slide. This was a health advisory alert that we sent out. Our state epidemiologist, Shannon McBee, sent this out, and it's small, but you have the slides, you'll be able to read over it. But this gives plenty of resources, background, and so on about it. Next slide. There are the links that you can go to find out more from the CDC, and then there's our Bureau for Public Health, which is our HAI page, and you can go there and find information too. Next slide. So CRS is not generally a threat to healthy people. One question there's a question where the index patients affiliated with long-term acute care facilities. Yes, mostly in long-term acute care. However, our most recent ones have been in acute care facilities, large health, in our large health systems. Thank you for asking. So one thing that comes up is people want to know, well, I'm a nurse and I'm in here. I take care of people that are colonized or infected. Am I able to spread this to other people? Yes, you are, but it is generally not recommended that we screen healthcare providers because just like in your own home, your biome and your physical, biological system is used to, for a lack of a better term, that's your environment. So if you're otherwise healthy, you are not going to be at risk of CRS. Using the good hand hygiene and practices will prevent that. Next slide. Symptoms, it can cause infection anywhere in the body. and it depends on the location and severity of infection. Generally, fever, chills, sweats, a low blood pressure, those are the most common. And we found CRS in patients of all ages, from infant, newborn, all the way up to 97, 100-year-old. It does not discriminate. It can affect everyone. Next slide. Typically, the people who are more susceptible are the sickest of the sick, those with underlying medical conditions, anyone who may be on a ventilator, have breathing tubes, feeding tubes, anything that is invasive, that automatically will make people more susceptible. Also, if you have a resident who has a history of, say, MRSA infection, then they are more prone to become infected with other drug-resistant organisms. That happens often. Anybody who has received antibiotics or antifungals, um, more than one over the previous 6 months, those people are very susceptible. Next slide. I touched on cleaning and disinfecting. Um, Cleaning obviously needs to be done before disinfecting, and that's to remove any impurities like dirt or whatever you could see. That goes first. List P is the list on the EPA website that does pertain to CRS. The use of no-touch devices, such as the UV irradiation and those vaporizer hydrogen peroxide units, should only be used as a supplement to standard cleaning and disinfection. So it's important that your environmental services staff understand their job is vitally important in controlling spread of multi-drug resistant organisms. So good training and the basics really need to be a focus. Next slide. I can't say frequent and thorough hand hygiene enough. It is absolutely required. Contact precautions need to be in place, and we encourage enhanced barrier precautions for the skilled nursing facilities. Next slide. As I mentioned in the toolkit presentation, single patient rooms are recommended when possible. When single patient rooms aren't available, then prioritize those for the people that are at risk or a higher risk for pathogen transmission. If it's someone who can't has a draining wound, uncontained secretions or excretions, those people would need to be in a single room. Acute diarrhea, anything of that nature. You could, like was done during COVID, you could cohort patients with CRS together if that is needed. And then transmission reduction in shared rooms, 3 feet apart if possible, the privacy curtain. And then something too that you might not have thought of, environmental services should clean the entire area on one side of the curtain, and then they would need to take off whatever equipment, protective equipment that they have on, and clean the other side of that curtain and bed area as if it was a different room. You don't want to cross contaminate from one bed to the other. Does that make sense? Okay, next slide. Contact or EBP is recommended for the entire duration of that stay, and that does include long-term health care settings. There are no specific interventions known to reduce or eliminate Candida auris at this time. As far as decolonization, I should point out. So once you are colonized with it, it's something that you will have indefinitely. Research may prove otherwise, hopefully sooner rather than later. Next slide. In our state, Candida auris is a Category 1 emerging infectious disease. This is the lab criteria. They need to report it within 24 hours to the local health department. And this slide goes into the type of testing. You'll see there presumptive lab evidence. It says detection of C. Humuloni, and that is the most commonly misdiagnosed Candida infection. If you see this Candida hamiltonii, then you need to have that double checked because it very well could be Candida auris instead. Next slide. Screening is the routine testing of patients without symptoms, but who may have had close contact with patients that were newly identified. So say you have a patient in your room, you would want to definitely screen his or her roommate or anyone who shared a bathroom with that index patient. If anyone is admitted to the same room where that infected patient had previously been and was then discharged, that room needs to be kept open at least one night to make sure you can get it thoroughly cleaned and disinfected. Next slide. Communication. Next slide, please. If you do a screening, and we do help with that, we will work with you to make sure you have all the equipment and everything you need. But this is a quick little look at what is in a little kit that you use for colonization. So you have your biohazard bag, and some of you may have already been doing screening. But if not, you have your biohazard bag. It comes with a sterile swab, a little square of parafilm that is used to seal the top of the swab once you collect your specimen, and then the patient requisition. If at some point you do screening and you're responsible for collecting these samples, please, please make sure you put patient identification on the swab itself. Most labs will refuse to accept swabs that don't have identification on it. They are forced to refuse it. So that causes extra problems. Next slide. This is a close-up of the instruction sheet on how to collect the specimen. Very simple. You use the swab to wipe in the axilla area, one arm, same swab to the other arm, and then in the groin, both sides. Next slide, please. Don't place that requisition in the main compartment with the swab. You can imagine that there are times that the swab somehow comes out of the plastic tube and it can contaminate the requisition. Anything that leaks or breaks is rejected. Next slide. There are special requirements if you ship biohazardous any kind of container. If it comes up that you will be doing screening, then we'll work with you on this one. But just know you can't just stick it in a box and send it off to the lab. Next slide. Next slide. Next. Your local health department has specific responsibilities, and they will be reaching out to you right away to get the process started to do screening and so on. Next slide. Next. We as a state, once the investigation is completed by the local health department and the regional epidemiologist reviews it, and then we at the state will get that investigation and make sure everything is taken care of and close out those cases. Next slide. Next. Next. These are just screenshots of our state system that we log on. You'll never have to worry about this part of it. Next slide. Next, next, next. Okay, frequently asked questions. I talked about this, that healthcare personnel can become colonized, but should not transmit to patients if you do follow those basic infection control measures. Next slide. Should we screen patients to document clearance of CRS? Well, if you heard me mention a bit ago, no, it is generally not recommended to rescreen for clearance. Number one, because clearance is not possible at this point in time, and people will remain colonized for over months or years. We don't know yet. More to come on that. Yes, Becky, you'll be getting slides of it if you haven't already, but we'll reach out with that. Next slide. Next slide. Are there false positives or false negatives with these tests? Yes. All testing, there is some degree of false positives or negatives, but you can work with your lab to help keep these to a minimum. When you do swabs, if you have to do that, just ensure that you get enough material on those swabs to have enough cells that they can culture. Next slide. How much time do we have? Because we can take up a lot of time on these case studies, and I don't know if you want to do that or not. If you're,
Kathy, I think we're at 2:45. It's probably a better idea just to see if there are any questions, Val.
okay, sure,
Thanks.
yes.
Yes, sorry. And I thought I was talking. I just realized I was on mute. There's a question in the chat. It says, and let me know if you answered this already and I missed it. It says, is the state currently recommended regular screening for any patient populations?
We do long-term acute care. We're working with those. We don't have very many of those in the state, but they are proving to be the most vulnerable. But in acute care facilities, you can prioritize whenever people are admitted and question them about out of country or out of state health care if they've received it. States around us, Ohio and Pennsylvania, well, and Kentucky also, they have higher rates of Candida auris in those states. So if it were me, I would also be asking, hey, have you, especially those border counties, have you been out of the state? So if they've been to a place where there's a high rate of Candida auris, then you'd probably want to go ahead and screen those people. But just those most vulnerable is who you should prioritize if you have to prioritize.
Thank you. And did you want me to show any more of these slides or head into the Q&A?
Just the Q&A, please.
Okay.
At the end of the slides, there is my contact information.
There we go. All right. So if you haven't asked your question already, please go ahead and submit it at this time in using either the Q&A tool or the chat. And while we're waiting, I'd again like to invite everybody to next week's webinar, which will be a follow-up on enhanced barrier precautions, and that will be next Wednesday at 2 p.m. We also invite you to bring your questions to our virtual live chats, which are every Tuesday and Thursday at noon, except on holidays, so we will not be having it tomorrow. One of our quality improvement specialists will be there to answer your questions on topics such as quality improvement initiatives, infection control, or MDS coding. You can find the links to our live chats and webinars in the newsletter we send out every Friday called the Last Minute Lowdown. And if you'd like to receive that newsletter but don't think you're on the mailing list, you can email me at caudill@qualityinsights.org and I will get you on that list. And I will drop my email in the chat shortly. I'd also like to note that I put the link to the presentation slides in the chat, as well as the link to that toolkit that we looked at the beginning of the webinar. The next question says, are there any recommendations for acute care to empirically place patients from LTAC and transmission-based precautions.
I would not recommend that at this point. I will do a little more research, and Brandy, I can get back to you, but I wouldn't say that that would be recommended right now. Similar to the screening prioritization, you could, as a facility, decide if you want to do that or not. But just always know, yes, you're welcome. Always know that whatever your hospital policy is, you need to follow that, because you can get dinged if you have a policy in place and you're not following it, of course. So
Right, thank you for your question. We just got another question. It says, does antifungal topical cream help for skin outbreak?
that I couldn't answer.
Hmm.
My first thought would be no, but I will need to dig a little bit on that one, and we probably don't have an answer
Hmm.
yet,
I think that's a good
unfortunately.
question. If anybody else has a question, please submit it at this time, and you could also raise your hand if you would like to request to ask your question out loud, since that might be faster than typing it out at this point. Valerie, is there anything else you'd like to add before we close?
No, I just thank you for listening, and if you have any other questions, it's my job here, is my whole focus is MDROs, so call me, email me. I'm happy to help.
All right, thank you. And I'll check the chat one more time before we close out. Oh, it looks like we might have a question. Someone said, thank you, great job. Thank
Thanks,
you so
Meg.
much.
Thanks, Emily. And can I do a shout out, please, real quick?
Sure.
Emily Melkier is my right-hand woman here. She is the one who put together that toolkit. So thanks bunches, Emily. You're the best.
Thank you, Emily. And I will be emailing everybody later this week with the link to that toolkit and the presentation slides in case you didn't get a chance to download it today. And I will go ahead and wrap this up, since it looks like that's it for questions. Before we sign off, we'd like to ask everyone here to please answer a short evaluation of today's webinar. It is anonymous and will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we'd appreciate it. Valerie, I'd like to thank you for joining us again this week. And I'd like to thank everybody here for joining us, and hope you have, yes, so one more person said thank you. Thank you. And thank you all for joining us. And we hope to see you again soon, and hope you have a happy and safe 4th of July holiday.
Take care.